We'll be starting our webinar titled Rapid Adaptation of Clinical and Pathways and Clinical Practice Guidelines. It's my pleasure to be the moderator for such an important webinar. And it's also my pleasure to present our expert speaker, Dr. Abdullah Hamad Al-Khmizan. Dr. Abdullah is a family medicine consultant with subspecialty in clinical epidemiology and evidence-based medicine practice. He's a consultant in King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Abdullah received his Canadian Board of Family Medicine in the year 2000 from the University of Toronto. He also completed his fellowship training in the same University of Toronto in the year 2001 of palliative and geriatrics medicine. He was also awarded the American Board of Hospice and Palliative Medicine in the year 2002. On top of that, he has master's degree of Health System and Quality Management in the year 2009 and master's degree of Medical Law and Ethics, University of Edinburgh. Thank you very much for being with us, Dr. Abdullah. And for our audience, please, if you have any questions, write them in the Q&A, and I'll be moderating and sharing the questions with Dr. Abdullah at the end of the lecture. You may start, Dr. Abdullah. Thank you very much.
Thank you very much. Bismillah, alhamdulillah, sallallahu ala rasulillah. Thank you very much again, and thank you for organizing this webinar. Honored and delighted to be, part of this activity. Clinical practice guidelines and clinical pathways are emerging as a very important way to standardize the care all over the world, but I think this is especially applicable in our country because the fact that we have people coming from all over the world practicing in our country, and that's why I think the emphasis on standardizing the care in our country is even more important than probably other countries. The fact that practice in our country also is variable and some sort of privileges, especially in certain areas, certain sectors, are not very clear. What are the privileges of somebody who is a specialist versus a senior registrar versus a resident versus a consultant versus a subspecialized consultant? It's not very clear in some of the practices in our country. That's why I think creation of clinical practice guidelines and clinical pathways are extremely important, and this is of interest of many parties in our country. One of them is the CCHI, the Cooperative Council for Health Insurance, which is getting more and more interested in these clinical pathways and clinical practice guidelines to try to standardize the care in the private sector. Also, other parties are also interested in this business. The Council for Health Services, Saudi Council for Health Services, the Saudi Commission for Health Specialties are also interested in this business. The different clusters now in our country are also interested. The Ministry of Health are also interested in this. And that's why I think it's very important to talk about these concepts. This is what I will try to do in this brief presentation. So I'll try to present a process of rapid local adaptation of clinical practice guideline and clinical pathways. So I will focus on, again, a rapid way of local adaptation, rapid and hopefully practical way of local adaptation of evidence-based clinical practice guideline and clinical pathways in our country. I mean, someone might ask, okay, what is the evidence that evidence-based clinical practice guidelines or evidence-based clinical pathways work or have extra benefit than other kind of usual practice? This issue was raised in a very strong way, like early in the 90s, because we did not, at that time, we did not have good evidence that the concept of evidence-based medicine and evidence-based clinical practice guideline and evidence-based clinical pathways will add much to the practice. But I think at this era, things are to a great extent clear. Many research was published in this field. The implementation of evidence-based clinical practice guideline, the management of patients with congestive heart failure resulted in more than around 8,000 quality adjusted life years pound for the suspected heart failure population. And the threshold where we accept, something to be cost effective is around 20,000. So it's clear that, that intervention was very cost effective. Implementation of IVIG pathways in an ICU setting was associated with a significant reduction in hospital mortality, reduction by 50% in surgical site infection following a protocol and pathway for prophylaxis, antibiotic prophylaxis to prevent this infection, reduction in hospital acquired ventilation associated pneumonia through the application of an evidence-based clinical pathway in the ICU setting, reduction in the mortality of brain injured patient following the implementation of brain injury clinical pathway, and so on. So I think this question is crystal clear. And if you think about it, what is evidence-based medicine? What is evidence-based clinical practice guideline or clinical practice pathways? It's the implementation of existing research, translating existing research into pathway to make sure that research will be implemented. And this is a huge issue in the field of medicine. Lots of research, but barriers when it comes to implementation. And that's why one of these tools to overcome the barriers for the implementation of research, of science into practice, is the utilization of evidence-based clinical practice guideline, evidence-based clinical pathways, decision support tools in the era of electronic medical records. And that's why, I mean, the whole world now is interested in this business, especially clinical pathways, because clinical practice guidelines involve the academia, the academic part of reviewing the evidence, while clinical pathways it's more directed to the healthcare professionals at the end user of the clinical practice guidelines. And that's why all clinical practice guidelines will most likely contain clinical pathways. And that's why many agencies now, leading agencies in the world, now they're focusing more on clinical pathways because it can consume time and be more practical in touching base with the end users. Like, for example, NICE. NICE now is shifting their resources, although they're still doing the clinical practice guideline. They are doing excellent clinical practice, evidence-based clinical practice guideline, but also they are shifting some of the resources to develop clinical pathways. We will come to that. Why we think of adaptation of clinical practice guidelines? Why don't we just develop, clinical practice guidelines from scratch, de novo? And the reason is because we don't want to reinvent the wheel. And some of those countries that develop really robust, high-quality, evidence-based clinical practice guideline, they spend huge amount of money and resources to develop these evidence-based clinical practice guidelines. And in our country, and many countries actually are taking this approach. We don't need to reinvent the wheel. Let's get high-quality evidence-based clinical practice guidelines or clinical pathways, and let's just do the adaptation and let's implement it in our setting. Countries like UK, for example, through NICE, which is like one of the role model guideline and clinical pathway agencies in the world, they invest a huge amount of money, like around 1 billion pound is the annual budget of an agency like NICE. A huge amount of money. I don't think this will happen in the near future in our country, and that's why let's utilize whatever is done by NICE, by the US Task Force for Preventive Health Services, by Queensland, in Australia guidelines, and other guidelines in the world, and American guideline, Canadian guideline agencies, and just let's build on them. Let's just go quickly through the process of developing evidence-based clinical practice guideline from scratch. So one of the most important methodology that was developed in this regard was developed actually by the Canadian task force on the preventive or on the periodic health examination, and they developed what they call the analytic framework methodology for developing clinical practice guideline, and this methodology was adopted by the U.S. Preventive Services Task Force in the 80s. I was actually lucky enough to be, the principal author of one of the Canadian Task Force guidelines. So I went through the process, and I know that it's a very demanding process. We took two years to develop a guideline about the use of antioxidant vitamins in the prevention of cardiovascular disease and cancer. This is just one item which relates to vitamin E utilization, and we do, you should do that. I mean, for different types of vitamins, vitamin A, E, D, B, and so on, B6, B1, and so on. So this is the targeted population, which is the adult, and the intervention is vitamin E, and there is intermediate, outcomes, which is oxidized LDL and other outcomes, whether it's associated or not with the reduction of morbidity and mortality, whether vitamin E, which is line number 2, which is whether vitamin E has direct impact on reducing morbidity and mortality without passing through the association, which is number 4. What are the adverse events? And you need to do that for all of these interventions. And for each line, you should create list of questions that you need to search for and try to answer. And you need to review the literature for each question. All these lines will create questions. Whether what's the prevalence of vitamin deficiency among adults, for example. This is number 1. Is there that evidence that vitamin E will reduce morbidity, cardiovascular disease, colorectal cancer, lung cancer, prostate cancer, and different type of cancer? These are questions that you list. Whether vitamin E will affect oxidized LDL, colorectal polyps, and other intermediate outcomes. Is there association between oxidized LDL and mortality and coronary disease and different kinds of outcome and so on? So lots of questions. You will end up with around 50, 60 questions with each analytic module, and each question you go and search for it. Then you start with another intervention, which is related to vitamin E, then vitamin B6, then vitamin B, then vitamin D, and so on. So a huge list of questions. You will end up with 600, 700 research questions that you should go to the literature and search for it and try to get the different studies that have studied this intervention. Then you go and review the internal and external validity. Internal validity relates with whether that study measured what it's meant to be measured within its own population. External validity, whether that study is applicable in your own setting or not, or in the general setting or not. So you go through systematic review, randomized control trial, cohort studies, case control studies, cross-sectional studies, demographics and of the study population, and so on. The different interventions. Then you create the different, we call it evidence tables, which has 2 dimensions. The first dimension is the evidence table that describe the characteristic of each individual study, including the quality, the comparative group, the different outcomes, whether it was blinded or not, if it's randomized control trial, are there any other confounder, did it have adequate power or not, and intention to treat principle was applied, adequate follow-up or not, and other questions which describe the characteristic of each study. Then you have to create another important evidence table which include the different outcomes and the result of different outcomes, using whatever statistical measure that was used, either relative risk or odds ratio, and what's the quality of that study, with any comment that you would like to add. Then you come up with the final conclusion based on all of these review in our guideline that was published by the Canadian Task Force. we concluded that vitamin E actually is not recommended. Actually, it's harmful because we found two major studies, large, huge randomized control trial that have shown that antioxidant vitamins, including vitamin E, is associated with harms, increase the risk of cancer, lung cancer namely, and increase the risk of hemorrhagic stroke, among other adverse events. So this was a recommendation. And by the way, when we published this recommendation, the U.S. task force was not happy about it because in the United States, the recommendation with vitamins is huge. So they decided to do it again. Usually, the Canadian and the American task force they collaborate with each other. So if I do something, you don't do that. You invest in something else. But they decided to do it actually. And when they did it, they came up with exactly the same conclusion. And that's why this is just for a simple, kind of evidence-based clinical practice guideline about, the use of vitamin E, very small entity, but think of something more comprehensive: hypertension, diabetes, something more big. You'll need huge resources to do that. And that's why we need to think seriously of adaptation or local adaptation of evidence-based clinical practice guideline and clinical pathways. What do we mean by adaptation? Adaptation is a systematic methodology for utilizing a pre-existing guideline and clinical pathway developed in one context, in the Canadian context, the American context, the Australian context, the British context, to be used in a new context, the Saudi context in this example, putting in consideration local circumstances and constraints. So it will reduce time, effort, resources, expertise in developing clinical practice guidelines and clinical pathways. So this will facilitate the utilization of also the evidence that was made in one setting, because studies, the field of medicine is not secretive. Most of the studies are published and are there. So if someone analyzed that study and that agency is a good, robust agency, probably you don't need to repeat what they have done, generally speaking. So we actually, there are different suggested adaptation methodology. I think we published one of the first actually adaptation methodology in 2004. There are other adaptation methodology that was adopted by international bodies, like ADAPT by the Guideline International Network in 2009, CAN implement by the Canadian agencies in 2011, SNABIT was suggested by 2014 in collaboration between McMaster University and other Canadian agencies. Rapid adaptation was suggested in 2004 and was evolved and developed more recently. Was suggested by a Norwegian group actually, and they collaborated with McMaster University to just prove the concept. And the analysis, the methodology is very interesting, and that's why I will focus on it today. Grade development is another methodology that was suggested by GRADE Group, a very important agency when it comes to the adaptation of clinical practice guideline, and they are led by McMaster University. So rapid adaptation and grade development, they are close to each other. I will focus on rapid adaptation. I think we have to be practical in this era. The fact that our healthcare system is changing rapidly. I think we need to match that with rapid adaptation. In the old days, we used to recommend using AGREE instrument whenever you try to do the local adaptation. AGREE instrument is a very important instrument that was established in around the year 2003, 2002, and it's a way to locally adapt clinical practice guideline. One of the most important steps is the selection of the clinical practice guidelines. So AGREE will rate different guidelines and will help you to select the best clinical practice guideline. However, the problem with AGREE, it's a very demanding instrument. It's a very long instrument. It contains 6 domains, 23 items, and you have to have at least 4, 5 different raters to rate these guidelines. Need special kind of training. The instrument itself also, in terms of validity and reliability, was not great in terms of the figures of validity and reliability, and that's why with the rapid adaptation they skipped this step, and I think it was successful because sometimes when you apply, I mean, one of our colleagues, he told me that we did an adaptation of anticoagulation guideline. And I asked them, I looked at it, they did actually agree, and they did not include a very important, authoritative kind of guideline, which is the CHEST American guideline, which is a standard of care all over the world when it comes to anticoagulation therapy. He told me no, because they did not pass agree instrument. So, and this is one of the problems of agree instrument. Some of the most robust guideline might not pass the agree instrument when you compare it to other smaller guidelines. And I told him, I told my colleague, I mean, if you did not include, the anticoagulation guideline from CHEST, I don't think anybody, any hematologist or internist will accept that guideline. And the same thing, when you, try to locally adapt a guideline about diabetes, you have to include the American Diabetes Association, the standard of care, whether we like it or not. And the same thing when it comes to hypertension, JNC, and so on. And that's why with this rapid methodology, which was suggested again by a Norwegian group in collaboration with McMaster University, you don't need agree instrument. So it's an advantage. Now let's go and talk to the this methodology of rapid adaptation of clinical practice guideline and clinical pathways. The first step is the step of planning. So you choose a topic like low back pain, or any topic that's related to this low back pain, for example, or back pain or neck pain. Then you have your team, usually 4 or 5, more or less, specialized in the area. Okay, it's better to be different, specialties. It will be nice to have other specialties, even other allied health with you, if possible, like physiotherapists, for example, nursing, maybe a GB, be part of the team, if possible. Of course, conflict of interest should be declared. Then you select 1 to 2 guideline or clinical pathway, or 3. So 1 to 3 clinical practice guideline or clinical pathways to be selected. So you don't go and search for 10, then you do agree, then you select among the 3. So this is one of the things that is like shortcut when it comes to the process of local adaptation of clinical practice guideline. These guidelines should be coming from international, authoritative guideline, if possible. Should be published within the last 2 to 3 years, just to accommodate any recent evidence. You should get the permission to adapt, and usually this is not an issue, because most of the clinical pathways and most of the clinical practice guidelines are published and public, generally speaking. So this should not be an issue, generally speaking. The level of evidence and grades of recommendation should be specified clearly within that guideline or clinical pathway, if possible. What do we mean by level of evidence? Level of evidence is the scientific evidence that support this recommendation scientifically. Grades of recommendation, this relate to whether this recommendation is applicable, whether the benefits of applying this recommendation outweigh its harms. And this depends on different things. It depends on the outcome we are talking about. It depends on the cost. It depends on the feasibility of utilizing and applying this particular procedure. So level of evidence is scientific, pure scientific. Grade of recommendation is the final message to the practicing clinician. It will be nice also to have the evidence tables that was conducted to come up with the final conclusion. Usually it will be published within the guideline. If not, you can ask for it, and usually, the group that developed it will provide you with the evidence tables, generally speaking. It will be nice also if that clinical practice guideline have used GRADE methodology. GRADE is an agency, not for-profit agency, that developed a new way of developing of rating the level of evidence. Deserve a full presentation, but I will talk about it in 2 minutes. So GRADE, the level of evidence and the grade of recommendation, level of evidence, which is level 1, 2, 3. Level 1, systematic review or a randomized control trial. Level 2, cohort studies. Level 3, case control cross-sectional studies. Level 5, experimental. This is the old way of categorizing evidence. Now, most of the agencies actually, they don't like this way and they don't accept it. Why? Because a robust, good, large cohort study might be better than a small, lousy, poorly organized and poorly designed randomized control trial. Based on the old school kind of grading of evidence, all randomized control trial will be level 1, be up in the hierarchy, regardless. Cohort studies will be number 2, regardless. When it comes to grade methodology, it depends. You need to look at, the certain details. As again, this deserves a full, presentation. But my point is, bottom line, grade recommendation. Some of the cohort studies will go above randomized control trial based on the methodology. Grade recommendation right now is used in almost all majority of agencies all over the world, including NICE from UK, including the WHO guidelines, including the American Task Force guidelines, including most of the guidelines now, even American Diabetes Association, just anticoagulation guidelines. Most of the guidelines right now, they are using grade methodology. So also part of the planning is to go and search for existing clinical practice guidelines or clinical pathways. Most of the guidelines, as I mentioned, will contain pathways. So you will find the pathways within the clinical practice guidelines, like the National Institute for Healthcare Excellence, NICE, from UK, one of the most important agencies all over the world when it comes to the development of clinical practice guidelines and clinical pathways, because they have a specific section for clinical pathways. Huge budget behind NICE. More than £1 billion is spent on this business, so they take it seriously. The Scottish also have a similar agency, SIGN, also very, very nice. The WHO now is more focusing on evidence-based clinical practice guideline, generally speaking. The Guideline International Network, they have a bank of guidelines and pathways can be utilized. Canadian Medical Association Infobase, as you know, the Canadian, they are the basis and the origin of the evidence-based medicine movement, and they are the origin of the clinical guidelines methodology. So they usually produce high-quality evidence-based clinical practice guidelines. Google is another excellent source, to be frank with you, because most of these guidelines, some of these guidelines are not published as a publication. So you might not find them in PubMed, but they will work on them, develop them, and publish these guidelines on the internet. Like NICE, for example, most of its guidelines are published in their website. You can access through Google. And the same thing with searching for clinical pathways. NICE has a very nice, section for clinical pathways, very well, organized. Cancer care in Ontario, in the field of cancer, they develop really robust, high-quality clinical pathways. Queensland from Australia, they develop high-quality clinical pathways. Again, Google is another important source when it comes to the development of, when it comes to searching for clinical pathways. And as I mentioned, majority of clinical pathways and clinical practice guidelines are available free on the internet. The next step for the rapid adaptation of clinical practice guideline, and these are the 5 steps for rapid adaptation. The second step is the assessment of the different recommendations. So this review panel that was elected will review each recommendation, and they will leave it stand as is, or they will modify it based on the local setting, based on the local resources, based on the availability of this or that intervention, based on cost, maybe based on maybe this is not a priority in our local setting for whatever reason, and so on. Maybe it's not acceptable way of doing things in our local setting. For example, in Malta, they managed to do to implement a very nice clinical pathway and clinical practice guideline to try to eliminate thalassemia in the country, and they managed actually to reduce thalassemia to by more than 99-point-something%. However, their methodology involved prenatal, intragestational kind of diagnosis of early on in the pregnancy of thalassemia and abortion, offering abortion. So, okay, it's very successful way of doing things, but will it be applicable in our setting? Maybe not. And some of these recommendations could be excluded for whatever reason: feasibility, local setting, culture, religion, scientific evidence, and so on. The group might need to develop new recommendation for specific gap area. It will be minor compared to the huge and overall guideline or clinical pathway. There will be few points that will need to develop a new recommendation. Modification also is a very important step, which include the feasibility of the intervention, of the suggested intervention. Maybe we don't have the resources to do this particular intervention. Maybe the medication is not available, the intervention is not available, the culture might not accept it. Cost could be a factor that okay, we need to modify. For example, when it comes to we did this actually in our setting, and the setting that I work in, we did a program for colorectal cancer. And we know one of the most very well established methodology of doing screening for colorectal cancer is to colonoscopy. Colonoscopy is one of the most important way of doing things. Colonoscopy, sigmoidoscopy plus other intervention. But if we are gonna send around 2,000 patients to colonoscopy, I will block the colonoscopy unit in our setting for the next 2 years. This is not possible. This is not feasible. So we utilize fecal occult blood. If the test is positive, we do colonoscopy. So it's very important to look at the feasibility and cost of any intervention that you think of. And you need to look at local gaps. Local gaps include what's the prevalence of this condition in our disease? Okay, this is a Canadian guideline. They talk about the prevalence in Canada, but okay, what's the prevalence in Saudi Arabia? Or what's the prevalence of what's the cost of this intervention? Okay, maybe it's expensive in that country for whatever reason, but maybe the cost is different in our city. Maybe. So local gaps, it's very important to address it and include it in the clinical practice guideline or in the clinical pathway. For example, when it comes to screening for diabetes, the general recommendation based on the American Diabetes Association and other agencies in the world at the age of 45. Okay, will this be applicable in our setting? If you ask me, I will say no. Because, okay, diabetes prevalence in the United States is 5%, UK 5%, Canada 5%, but in our country it's 25% of the adult population. And the other 25% of the adult population are pre-diabetic. So for me, I will lower the age of screening to probably 18. And we have data that, by 18, around 12% of the population are pre-diabetic. So we have to adjust to local setting, extremely important. Also, guideline or clinical pathway that was published in even 2018 or 2019 could miss important landmark publication in 2020 or in 2019. So you probably should adjust your clinical pathway based on landmark publication in the field. Also, I mean, you need to do an updated literature update, literature search and update if there are any landmark studies in the field. For example, in the field of diabetes, recently, a few weeks ago, when the American Diabetes Association published their a new recommendation of adding another medication in addition to metformin. Metformin used to be the standard of care, but now they are adding actually other intervention, other medication, mainly SGLT and GLP-1 as a medication to protect the heart, mainly, regardless of the hemoglobin A1C level. So this is a new recommendation that need to be addressed and included. So you have to update the literature using midline search, using most updated systematic reviews and meta-analysis, and so on. Part of the modification is the fact that you will end up developing a new recommendation based on the local setting, based on the feasibility, based on the limitation, local limitation, and so on, and based on the best, most available evidence and most recent available evidence. Also, it's very important to use grade methodology as much as possible when you try to incorporate and rate the new recommendation and new evidence, if you have to do the analysis yourself, because the most recent evidence you might need to do your analysis yourself with the help of experts. Of course, you have to consider the patient, our patient, providers, and cultural factors within the guideline. And it's important to send all these recommendations for local peer review and international peer review if needed. The fourth step is to go ahead and publish the paper. You can publish it, of course, online, and let people comment on it, receive the comment, and you can act upon it. Publish it if you are targeting clinical practice guideline. You have to publish with it clinical pathway, because as I mentioned in the beginning, clinical pathway is very important for the end user. It's for the really the actual end user. They are not many of them. They might not be willing to read your 10-20 pages guideline. They want like 1 or 2 pages that with a diagram that describe the whole guideline, so they can scan it quickly and implement it, put it in their office for which will ease the implementation of the clinical practice guideline. It's also very important to summarize the recommendation based on the clinical practice guideline if you are targeting clinical practice guidelines. Very important also to publish a layperson summary. We are in the era of empowering patient. So it's very important to publish a layperson summary. This is what NICE is doing. This is what the Cochrane Library, for example, is doing. And it's extremely important. We have to empower our patient to help in the implementation of the clinical practice guideline and clinical pathways. You have also to have implementation tools. And one of the implementation tools is the auditing tools. Like, okay, this is the number of MRI that is expected to be done, in a general population. If someone is doing more MRI for back pain, this means he's probably abusing the system. He's probably abusing the investigation. maybe X-ray, maybe advice will be enough. Unless if he's a subspecialist or specialist, that's a different story. And the same thing with diabetes, auditing tool, hemoglobin A1C less than 7 in 50% of the population, for example, or whatever figure you think is applicable in the local setting. Of course, all of these guidelines and clinical pathways need to be updated every 2 to 3 years. The fourth step is the step of publication of the guideline and the implementation of the guideline. So there should be a training manual describing the guideline, giving some 2 or 3 clinical scenarios on how to implement the clinical pathway or the clinical practice guideline. Clinical pathway is a very important part of the clinical practice guideline. If you are publishing already a clinical pathway, that's fine. You might not, will work by itself. There should be indicators for monitoring, as I mentioned. Rate of MRI request, for example, should not exceed certain percentage in the family medicine GP level. Hemoglobin A1C should be, with this figure. Auditing tools also is another important. How to audit, how to monitor the implementation of these guidelines is also are also important. Then the fifth step, or step number 5, is the evaluation of the clinical pathway, which include feedback from peers, from the recipient of these guidelines, reviewing the new evidence in case anything is published, updating the guideline. So this is the summary of the methodology for the rapid adaptation of evidence-based clinical practice guideline. Starts with topic prioritization, then finding 1 to 3 pathways and guideline, then getting the different recommendation of these clinical practice guideline, taking the permission to adapt, assessment of the pathway and the guideline, looking for new evidence to cover local gaps, and modification of these guidelines accordingly. Then develop your own new recommendation if needed, and finally peer review, then publish, then evaluate and reassess and modify the guideline. And the same thing, apply on clinical pathways. One of the, in terms of the different softwares that can be used for mapping the clinical pathways, one of them is the PowerPoint, simple, easy to do. But there are more specialized kind of, softwares like Visio, which is cheap, not expensive. Lucid Chart also is another, tool that can be utilized to map the clinical pathway. Cost around $100 per year, around this figure. Some of the agencies, like Cancer Ontario, they recommend using different codes, like primary care, certain code, secondary care, surgery, radiology, different codes for different service when you try to map the clinical practice guideline, clinical pathway, and different shapes for the guide or the pathway. So intervention, square, decision assessment, exit pathway, circle, and so on. And I think it's really useful to utilize these legend for the pathway. I think it's very interesting being implemented actually within Cancer Ontario, and I think it's very interesting. It's nice to be implemented. This is, for example, as an example of a clinical pathway related to colorectal cancer screening from Cancer Ontario. Again, as you can see, very comprehensive, and they will put numbers, and you can refer to these numbers down like as a legend attachment. They will describe more details related to each step if needed. Queensland from Australia, again, they produce really high quality evidence-based clinical practice guideline available free on their website. This is one guideline in the field of cardiology, chest pain, with description of the different intervention in a very nice, comprehensive way. NICE, the mother of all, clinical practice guidelines and clinical pathways. They have a specific actually section within NICE devoted for interactive clinical pathways. This is for the management of back pain, and as you can see, each step is given a number, and then they will describe and talk in more details about that specific number 9, additional specific treatment for sciatica, and they give different suggestion, and they give you different links for other pathways and guidelines that is linked to this issue. Other surgical procedures, they talk about other surgical procedures with links related to these other surgical procedures. Having a training manual attached to the clinical pathway and clinical guideline, I think is very useful. Should be case-based training manual, 3 to 4 cases, just for the general practitioners. And to be frank with you, again, not all consultants are on the same level, especially in our country. People are coming from all over the world. So it would be nice to have 3 or 4 cases, even for consultant specialists, to just give them a guide how to implement these clinical pathways. It would be nice to be attached as a PowerPoint presentation, if possible, because you want people to utilize it in their training. When you prepare it and you put your logo, the logo of the Saudi Society, for example, of spine, or cardiology, or pain and anesthesia, so people can utilize it with the logo. It will be a nice contribution to the education within the community. For example, this is from NICE. This is for unstable angina, and as you can see, they have a summary version. They have guidance into practice, how can you use this, and they have a clinical case scenario. If you click on the clinical case scenario, they will have different cases describing how to utilize this guideline or pathway, using different clinical scenario. John, 65 years old, then they will give you the case, then we'll try to resolve the scenario based on the clinical pathway. Thank you very much. This is the end of this brief presentation, and thank you very much.
Thank you very much, Dr. Abdullah. Very informative, comprehensive presentation. We have a few questions from the audience. From Dr. Ma'moon, he's asking, how can we get permission to adopt, and to what extent can you adopt, and can you merge several guidelines together in one adaptation?
Generally speaking, most of the guidelines are available free on the internet, and the agency like NICE, like Queensland, they put it on the internet because generally speaking, they don't mind to share it with the world. So you can communicate with NICE, send them an email, or Queensland, or Cancer Ontario, or any other agency. Generally speaking, most of the agencies, they will not mind you adopting their guideline. Generally speaking. And this is the beauty of the rapid adaptation, as suggested by the Norwegian and McMaster group. You don't need to get 6, 7, 8 different guidelines, because this is the old methodology. Adapt and other old methodology, they recommend actually to get 4, 8, 9, as much as you can. Then you rate them using agree instrument, using 4 or 5 raters. A very long story will take you at least 6 months just to work on this business if you are successful. And that's why now focus on scan the guideline, focus on 2 to 3, and adopt. Do your local adaptation based on these 2 to 3 pathway or guidelines.
All right. Second question. So you mentioned the layperson summary. The question is, if we do develop our own guidelines, do we need to translate in Arabic part of it?
Absolutely. I think it's very important to have a layperson summary. You don't need to translate the whole guideline. I think because English is the main language among healthcare professionals in our country, so I don't think that shouldn't be an issue, generally speaking. But it will be nice to have a translation of the summary So we empower our patient. So the patient come and ask his physician, okay, I have this. Okay, I'm due for screening for colorectal. I need to do it, or a mammogram, or whatever related to this particular pathway. Or if you think that for back pain, if you have these symptoms, you need to go to the emergency, and maybe a surgical intervention is the resolution. So we have to empower a patient.
Okay. Next question. So is there any difference between pathways for hospital and pathways at the society level that covers the whole country, or they should be identical?
I think the setting is different. We talk about primary care, different resources, different capabilities, different privileges, when you compare it to in-hospital care. And I think that's why I think in general, we should have, a guide for the, and as you know, our country with the transformation, there is a new focus on primary care, family medicine, primary care all over the country. But we have a major problem in our primary care, current primary care system. Majority of those who are working in the primary care centers, they're not trained as a GP or family physician. The majority of them are MDs. They just graduated from university, and they're working there as a primary care physician. This does not happen in most of the settings in the world. It does not happen in UK, in Canada, in the States. And that's why they deserve to have some sort of guidance when it comes to back pain, for example. This is their limitation. This is when you see these red flags, you have to refer to the specialist in the hospital. And that's why I think we should have, in most of the guidelines, we should have different sets. One targeting primary care physician and one targeting in-hospital subspecialist, specialist, kind of care.
Okay. Dr. Reem Al-Bnayan is asking, in your view, what groups are most suitable to lead the process of guideline and pathway adaptation?
I think, the best way to do it is to do it through specialists in the area with some, again, where our country's healthcare is transforming in our country. Most of the care with the new, model of care will be taken care in the primary care setting. Yes, it's not happening right now. It's happening slowly, but it's for sure it will happen because this is the focus of the country. And that's why I think we need to involve a few GB, family physician, primary care physician within these most of the guidelines, unless if it's something subspecialized, treatment of oncology, which will never be done by a family physician. I think you don't need a family physician, but I think most of these guidelines, management of back pain, for example, management of chest pain, you need to educate and involve those primary care physicians within the development of these guidelines.
All right. Next question from Dr. Leo. Is there numeric ranking in grade methodology, like the level of evidence? If so, how many grades? And can you say it in brief, please?
Grade deserve a whole presentation, and it's extremely important concept. Grade has a different philosophy. So for all randomized control trials, they will start high in the level of evidence. However, they can be lowered with certain criteria, including the randomization, the follow-up rate, the intention to treat, and other parameters. All observational studies will start low, but they can be, raised in the hierarchy of evidence based on different criteria, including consistency. More than one study is giving the same, and including different, parameters again. So grade methodology take a different approach, and that's why you might see a randomized control trial or a cohort study higher than the randomized control trial in their analysis in the hierarchy of evidence. And grade it's extremely important to understand grade, to be frank with you, because grade now, in the old days we were saying, okay, it's too complicated, let's not mention it to the general healthcare professionals. But now we have to, because now if you go to WHO guideline, if you go to anticoagulation chest, if you go to American Diabetes Guide, all guideline now, they all mention grade.
All right. Next question. So you mentioned the difference in cultures and in societies and in different parts of the world. So there's a question that taking surgical site infection clinical practice guidelines and antibiotic prophylaxis. And in this setting, in our country, we have high rate of diabetes, and in theory, we have higher incidence. Do we need our local studies first to identify the incidence of surgical site infection and then do our clinical practice guidelines, or should we just adopt what they have in other societies for this particular topic?
If you ask me, I will say we have to go and adopt. And in terms of the, part of any guideline, any pathway, you just give a brief description of the current situation in the country. So we need to go and try to get from the literature, what is the rate of, post-surgical infection, for example, in our country? And you mentioned it. Unless if you think that, okay, there is something unique about us, then you change it based on the local setting. But in general, we adopt whatever is recommended internationally, unless if there is something logically that need to be changed, yes, we change it.
Okay. We have 2 more questions. And in your opinion, who should develop the clinical practice guidelines? Is it the societies or the Ministry of Health?
Ideally, personally, I think ideally there should be an agency in our country devoted for developing clinical practice guidelines. Something like what we see in UK, NICE, for example. And I mean, again, Queensland, they have one department that is working on this. You can work with that agency, can work with the different societies to develop these guidelines. And that agency should be also have some authority. Again, I think personally the best model in the world when it comes to the implementation of clinical practice guideline, because development of clinical practice guideline is a challenge, but implementation is another huge challenge. The nice thing about the UK system, generally speaking, they have their problem, they have their issues, is the fact that it's one agency that develop and execute. So they go and measure. They have the right to go and measure in each hospital. What is your rate of XYZ? And there are financial incentives attached to. If you have your vaccination rate exceeding certain number, okay, you will get more money, and it's financial. It's always nice to say that we don't care about financial as physician, but in reality, this is what's happening in UK. And actually, in UK, they put certain standards, and they thought that the bar was very high, and they were surprised that practices are exceeding that bar. I mean, the explanation, my opinion is the fact that was attached to some sort of financial incentives, and that's why people were working hard on it. I think this is the ideal situation. Well, it's not happening in our country. I think there are thoughts around it, different agencies, different, but unfortunately not yet implemented. Currently, in my view, the best way is to support the different Saudi societies to develop these guidelines.
Okay. So one last question, and then we'll have to conclude. So Dr. Khalid Asiri is asking the opposite. If we have local guidelines, and should we merge it with international guidelines to improve it, or just utilize our own local guidelines or regional guidelines?
It depends. I mean, if it's robust, built on all of these, stringent criteria, will be nice. I mean, I've read most of the guidelines in our country personally, and I can tell you majority of these guidelines are developed like with some sort of adaptation. Very few guidelines that built that evidence table from scratch for all of their recommendation. I'm not aware of any actually. Majority, they developed their guideline based on local adaptation. Otherwise, the work behind developing a guideline, I mean, is really huge. You need huge resources.
All right. Dr. Abdullah, it was an excellent presentation, an excellent review for this very important topic. Thank you very much, and hope we will have more chances in the future to give us more details and more great topics like this. Thank you.
Thank you very much.
All right. Take care. Thank you, everyone.